Good morning, everybody. Good morning and welcome to everybody. We are talking about hormones today. And there's no doubt that hormones and endocrinology have really been thrust into the spotlight during this COVID era. We know that hormones play a really big role when it comes to certain diseases like obesity, lots of rare diseases, many cancers as well. And as a result, this hormonal dysfunction is really making us all so much more vulnerable to COVID. And so this is a big issue that is really taxing the researchers at the moment. And we want our discussions today to focus around a new white paper. In fact, it's the first ever white paper from the European Society of Endocrinology. And it's basically really looking at the place that hormones should be given in European health policy. So we, of course, want your questions. You'll see, you know that there's the Q&A at the bottom of the Zoom screen. So we're using the Q&A, not the chat, the Q&A to ask your questions. If you could keep your microphones and your cameras muted and off, that would be great. We're just going to ask the speakers to open their cameras and their microphones when we come to them. So it's going to be a very fast-moving meeting. We've got a lot of speakers, lots of different themes. So I really want to start by introducing you to your real host. And he is Professor Dr. Andrea Giustina. He is president of the European Society of Endocrinology. He's a member of the Italian Superior Health Council, pro-rector and chairman of the Institute of Endocrine and Metabolic Sciences at the San Raffaele Vita Salute University and the San Raffaele Hospital in Milano. And Professor, I think you're in Milan now.
Absolutely. Ciao, Katie.
Ciao. Take it away. The floor is yours.
Hi, everybody. My name is Andrea Giustina. As Katie said, I'm the president of the European Society of Endocrinology, and it's a great pleasure to host all of you today for the launch of our first historical white paper. And as Katie wonderfully said, this is something that was unprecedented in the history of the society. And our aim is really to be able to put hormones in the top of the agenda of health institutions. And this white paper will be the basis for all the interactions that in the next months and years we will have with European institutions. Today, we have a wonderful panel, as Katie said, of scientists and of people that really care about endocrinology, MEPs, the prominent members of the European Commission and Directorate General. So I want to hand over to Katie, since I don't want to steal too much time. Welcome, everybody. Hope that you will be enjoying these 2 hours with us, and hopefully the result will be really being convinced that endocrinology and hormones are important for European health policy. Thank you, Katie.
Thank you very much indeed. Well, we're going to start off with a voice from the European Commission, so it's really important. We're delighted that John Ryan is with us, the Director for Public Health at the European Commission, Directorate General for Health and Food Safety. So much easier to say DG Santé, which everybody in the EU bubble does, so we all know. John, lovely to see you, and we're very interested to hear what you have to say on this topic.
Good morning, everybody. And first of all, a big thanks to Andrea Giustina, the president of the European Society of Endocrinology, and also to the society itself for having organized today's event and the white paper, which I have read with great interest. Of course, we're in the middle of a worldwide pandemic at the moment, and I think we need to also take account of the impact of COVID on health systems, both now and in the future. The European Commission has drawn some lessons already, in the sense that we have called for a reinforcement of our legislation on cross-border health threats. This is being discussed at the moment in the European Council and the European Parliament, but also we have called for reinforcement of our health agencies, the European Centre for Disease Prevention and Control, and perhaps of interest for you is the mandate of the European Medicines Agency is also being strengthened. So all of this is going on at the moment based on a first evaluation of where the gaps are in our COVID response. But I wanted to mention as well to you the fact that the Commission has published as well a pharmaceutical strategy, which we are in the process of implementing at the moment. This pharmaceutical strategy looks at ensuring access for treatments, looking at unmet needs for treatment, looking at competitiveness, sustainability, and innovation in our pharmaceutical industry. And finally, the big COVID issue, I would say, is the security of supply of pharmaceuticals. So there's a whole area of activity there, which is also relevant for your organization, I think, and for your stakeholders. You mentioned in the white paper several times the cancer plan. The European Cancer Plan is a multi-annual major cross-cutting plan with a dedicated budget where we have listed a whole series of activities which in fact include public health, prevention, early detection of cancers, treatment of cancers, and also the idea of how to improve quality of life and care for cancer patients. And underlying all of the cancer plan is the issue of inequalities. We don't want this plan to make the inequalities bigger. We want to try and identify inequalities and reduce them across Europe. Yesterday, we had our first meeting with the member states to actually work out how this plan is going to be implemented. I should mention as well the digital health space, building on all the work that's been done on e-health over the years. You also mentioned this in the white paper, and I find this very forward-looking and very interesting for all sectors of medicine, that we try and make use of IT and artificial intelligence in the future. Now, how are we going to do all this? We're going to do it through legislation, but also looking at financing interesting projects across Europe in the next 7 years. Because we're very lucky in Europe, we have a 7-year multi-annual financial framework. And just to mention that as a result of COVID, the amounts which have been allocated in the European budget to health have been vastly increased. We have a Europe for Health program, which has a 7-year budget of 5.1 billion euros. And we have a research program for health, which has a 7-year budget of 8.1 billion. So to repeat those figures, 5.1 billion for the health program and 8.1 billion for the health research program. These are substantial amounts. We have had a consultation on the areas where we should be focusing in the first year, and the work plans, this is for attention of colleagues online who may have an interest. The work plans for both of these programs, the EU for Health program and the research program, will be published in June next month. So you will already have quickly an opportunity to look and see which areas of work you might like to apply for funding. Turning now quickly to the white paper itself. First of all, congratulations on the excellent scientific nature of this document. There are many footnotes, which is always a good sign, I think, in terms of the references that you give. The evidence base is certainly there. I was impressed by your linkage to the cancer plan, to the issues around obesity, farm to fork, nutrition. I think this is really important to also talk about prevention. But also you mentioned the European reference networks and widening those networks in the future. You focus also on registries for rare diseases. You mentioned the need to fund orphan drug development, and you mentioned health technology assessment. And all of these issues are being looked at the moment in the context of the Commission's work plan, particularly health technology assessment. We're making finally some progress with the Portuguese presidency in the lead. And finally, you mentioned national rare disease plans, which need to be reviewed and implemented. So with those few words, thank you again for the invitation this morning. Congratulations on the quality of your work. And I look forward to working with the European Society of Endocrinology and with Professor Giustina and his colleagues in the coming years. Thank you.
Thank you very much indeed to John Ryan, and very heartening there that a number of the issues that have been brought up in the white paper are actually being looked at Commission levels. So much going on in the world of health policy. So John, thank you very much indeed. We're going to hear more about the white paper that we've been referring to in a moment, but we really want to start with an overview of the role of hormones in health and disease in the pandemic and the post-pandemic era, because it is really important, as we've already alluded to. We're going to hear first of all from Sirpa Pietikäinen, who is a Finnish member of the European Parliament, a substitute member of the Committee of the Environment, Public Health and Food Safety, the ENVI committee. In February, she published an article in the Parliament magazine called Hormones and COVID-19, an alarming link. Some of you will probably have read it. And very interesting piece that it is. So we're delighted to have you with us, and I know that you're going to tell us more about that. So, and really where you think research should be going in the future. Thank you very much indeed. Delighted to see you, Sirpa Pietikainen.
Thank you, and thank you so much, first of all, to the European Society of Endocrinology and your president, Andrea Giustina, for inviting me today and for organizing this event, because I think that we are in the crux of one of our major health challenges, untouched health challenges in the future. And as you were saying, I published in February the article about the hormones and COVID-19, because I believe that this pandemic has shown clearly the linkage between endocrine conditions and COVID-19. And then we know, and there's alarming new information, what is the linkage between endocrine disruptors and different kind of metabolic diseases, diabetes, cancer, vitamin D deficiencies, and even Alzheimer's and a couple of the others. What is alarming is that I heard about these endocrine disruptors and their consequences more than 30 years ago. And already then we had quite sort of a significant proof to use precautionary principle and legislate a stricter limits on the use of substances that have the substances of endocrine disruptors. 30 years we have talking about this. And as a co-chair of the MEP interest group in the European Parliament to fight against the endocrine disruptors, we have been 3 times raising this issue in questions to the Commission, in the resolution, and in different calls. And even the Commission was sued by the Swedes to EU court of not bringing the guidelines and better legislative frameworks and the criteria, that case about the endocrine disruptors. Why does it take it so long for us? We do have the adequate knowledge globally. We do have the candidate lists. And we do have the precautionary principles. And we know that this is a complex issue, that the results are not to be corrected later on. For example, even the results for our common level of knowledge and intelligence in upcoming years. So I think that we surely should take this issue very seriously, both in the Council, in the Commission, and you can be certain that the European Parliament is working on these lines. And as you probably know, the last year, a large majority of MEPs adopted the resolution calling for a comprehensive legislative framework on EDCs. And now we are expecting and hoping the Commission to come up with that legislative framework as soon as possible. It has not yet materialized, and I'm glad that we can hear Giustina de Avila from the Commission later today to explain what are the regulatory next steps. Well, there would be a lot of challenges and the possibilities in the framework of EU for Health, the common data space, creating a endocrine disruptor reference network, more resources on the research and so on. But what I would like to do now is to turn the floor for real experts, and I'm looking forward for very interesting area of interventions and discussions and food for thought for all of us. Thank you, and sorry for my voice. That is because of the allergy and spring. That matter, the spring is a good thing to come.
Well, thank you very much indeed, and I hope it gets better soon. But I mean, clearly frustration there about the lack of action on endocrine disruptors, and we will be talking about that a little bit later this morning. So thank you very much indeed. We're now passing back to Professor Giustina, because you're going to tell us, I think, some more about the white paper that we've referred to, but we haven't really gone into the detail of. So, and you can tell us a little bit more how we're going to pursue that today. So, Professor. Your microphone's not. Yeah.
Yes, you're right. Thank you very much, Kathy. I would like, first of all, to say hi and thank you to John Ryan and to Sirpa for their friendship, for being here, for demonstrating to be so close to the world of endocrinology and of hormones, and for their actions and for their ability to tackle the situation, which is obviously very difficult for all of us. What I would like to say is that I totally agree with Sirpa. The COVID-19 pandemic disclosed, if it was necessary, the importance of endocrinology and of hormones in our health. We know now very well that people affected by endocrine diseases like diabetes, like obesity, people that have vertebral fractures from osteoporosis, people that have lack of vitamin D, are all at risk of severe COVID-19. And this is something that when we speak about prevention, we have to have clear in mind that the role of hormones is of paramount importance for preventing even infectious diseases and the complication of infectious diseases like COVID-19. Therefore, the importance of endocrinologists and the importance of taking care appropriately of endocrine and metabolic patients around the world and specifically in Europe is an issue which has become really a top priority for everybody. We really know that almost 2/3 of the patients that die from COVID-19 do have a metabolic complication. And this is something that really is striking. And we will talk really about the white paper on topics that, like obesity, are of paramount importance for preventing the the prevention of the severity of COVID-19. Obviously, the white paper will touch on other aspects that are of paramount importance for the health of the population, because clearly there is a relationship between hormones and cancer, which is also extraordinarily important. We know also that patients with cancer may be really also vulnerable to COVID, and there are many tumors that are not only the classic endocrine tumor, the thyroid cancer, but tumors that really affect many people, like the breast cancer, like the prostate cancer, that are hormone dependent tumors. And there are very interesting data on the role of some treatments for prostate cancer that block the androgen effect, that really can have some implication also in COVID-19. So the world of hormones is so big, is of huge importance for all our community, and really taking care of them is the priority, not only for us, but should be for all health and European institutions. Clearly, the white paper will touch also and is touching also on endocrine rare diseases. We will never have to forget rare diseases as something that we need always to keep under our attention, as Sirpa also was talking about endocrine disruptors and our environment, and how much what is in the environment can be damaging the endocrine system. I think that all these topics really make this event special. And again, thank you, John. Thank you, Sirpa. I thank all the people that have joined us today, because I think that is an historical event. Thank you, Katie. Back to you again.
Thank you very much indeed. I mean, that statistic, 2/3 of COVID deaths have people have a metabolic complication. I mean, that is quite something, that statistic. So thank you very much indeed, Andrea. We will talk to you a little bit later. We want to now talk about, we're basically going to divide into various sections of our conversations. And on the whole, we're having an endocrinologist and a policymaker in each of the sections. At least one of each, so that we can get both sides, the policy side and the scientific side. So we're starting with obesity as an issue. Huge challenge for society. We know that. It's talked about, though, as mainly a lifestyle issue, but there can be a strong hormonal component. So to discuss this, we have Christian Silvio Boissoy, who is a Euro MP, the EPP, chair of the ITRA committee, which is Industry, Research and Energy, and rapporteur for the EU4 Health Programme, also a trained physician. Delighted to see you. And Professor Dr. Liesbeth van Rossum is head of Obesity Centre at the University of Rotterdam in the Netherlands, co-lead for diabetes, obesity, metabolism and nutrition within the European Society of Endocrinology. So Professor van Rossum, maybe you would like to start off and just give us a little bit of the science behind obesity as an endocrine disease.
Yes, thank you so much, Kathy. Currently in Europe, almost 60% of the people is suffering from obesity or pre-obesity, so overweight. And as we all know, that's leading to type 2 diabetes, cardiovascular disease, but also to diseases like depression, 13 forms of cancer, and as we clearly see right now, a more severe course of infections, just like COVID-19. But at the same time, it's really important to realize that fat is basically an organ. It's producing hundreds of hormones and other substances. And these hormones are essential for life. They regulate, for example, your immune system. They talk to the brain, to other parts of the body, but they also regulate how much food do you take and what is your metabolism. Now, you can imagine if you have too much fat, this fat becomes sick. All these hormones become, they are dysfunctioning. And basically, then obesity is not about weight, it's about your fat, which is an organ, which is sick. So it's just not a layer of insulation or fat storage, it's an active organ, and that's sick. It's just like a liver or a heart can be sick. So we need to understand that obesity is basically a chronic endocrine disease. Now, another important point is that when people already suffer from obesity, it's really hard to lose weight. We often say, well, eat less, move more, but the hormones are being disturbed. And that means that your body is basically being reprogrammed. For example, one example is the fat hormone leptin. And normally in the normal situation, leptin regulates that if we eat, we stop eating because we are feeling full and our metabolism is being stimulated. But if you're obese, your brain doesn't sense the leptin anymore. That means that you're more hungry, your metabolism slows down, that makes you prone to gain even more weight. And it counteracts also weight loss. So many other hormones are being disturbed as well. And we need to know that it's really hard to lose weight. Also, when you succeed to lose weight, for example, you have a really healthy lifestyle, you lose weight, then all kinds of hormonal mechanisms in the body will counteract that weight loss, which makes it really hard to lose weight. And if you realize that, then you know that we often need more intensive therapies than just telling people to eat less and move more, but we should do combined lifestyle interventions, really guided, thorough programs. And if it's not effective, not wait until other diseases develop, like cancer or heart attack, but treat and add on treatment with, for example, pharmacotherapy. Also, endocrine therapies are available, which are really effective, or perform bariatric surgery if there's severe obesity. And also bariatric surgery is altering the communication of the hormones. So basically pharmacotherapy and bariatric surgery help to recover the hormonal disturbances. So I think it's also important to realize there are many causes of obesity. Of course, the most common cause is unhealthy lifestyle, but there are other causes like hormonal causes, but also medication, psychic causes, but also genetic causes, social factors. Well, there are many factors, but once you have obesity, it's hard to lose weight because it's an endocrine disease. So I think that's really important also for the weight stigma people suffer from. Also, endocrine disrupting chemicals can be leading or contributing to obesity. So that's really something we can do something about with the policy. So what we need to do right now is to recognize the central role of hormones and recognize also that obesity is a chronic endocrine disease, which is relapsing over the time, and to take it seriously. Now we are often waiting until a heart attack exists or a cancer develops, and then we start treatment. We have to take obesity seriously. Basically, the situation is right now that there's a water tap open and the bath is full. And I mean, with the water tap open, well, we need to close the tap because there are more and more people developing obesity. So that's important, more prevention to close the tap. At the same time, the bath is already full. So people who have already obesity, only prevention is not enough. You need treatment to empty the bath. So close the tap and empty the bath. With respect to prevention, we need more public awareness. You can think of national action plans, and also there's a lot of room to reinforce the farm to fork strategy, stimulating healthy environments. Also, we need price incentives to stimulate the healthy food intake. We have room also to phase out the endocrine disrupting chemicals, which can contribute to obesity, and we need appropriate resources behind prevention and treatment. With respect to the treatment, I think it's good to partner with the Endocrine Society of Endocrinology, but also with the EASO and other multi-stakeholder initiatives like the Open EU. So to summarize, I think now the situation is we have the tap open and the bath is full. We have to close the tap. We have to empty the bath and partner also with the endocrine specialists to really combat obesity and to prevent many of the 230 complications of obesity. So thank you for your attention.
Thank you very much indeed. A great analogy there. The tap is open and the bath is full, and the fact that fat is an active organ, that's something that people are not really aware of, are they? Then it can also be sick. But the main thing is to recognize obesity as a disease and to destigmatize. Very interesting. So let's bring in Christian Borsoi from the European Parliament and talk to you about the political work that you have been doing on obesity.
Thank you so much. Thank you for inviting me to this very interesting discussion. And yes, I believe that there is a moment to act, and we should use this momentum in order to advance the agenda of healthcare. Obesity is a serious public health concern as it significantly increases the risk of chronic diseases, as it was said before, such as cardiovascular disease, type 2 diabetes, high hypertension, coronary heart diseases, and certain cancers, as it was already described by the president of the endocrinology organization. There is a high prevalence of obesity and overweight among the general adult population in European Union, and we need to react. On average, 51% of Europeans are overweight, 14.9% are obese. The World Health Organization rightly speaks of a global obesity epidemic. The causes of obesity are multifactorial, and they were briefly described by Professor Lisbeth van Rossum. Determinants can arise from non-modifiable factors such as genetics to modifiable behaviors such as dietary and nutritional aspects to physical activity or inactivity and sedentary habits, and socioeconomic circumstances such as poverty. In your white paper, you describe obesity as a condition that is characterized by a disturbance in normal metabolic homeostasis, as an endocrine condition, thus a chronic condition. Indeed, obesity is fast becoming the most prevalent health issue globally and in the Union, and the link with increased comorbidities is clear. At Union level, the Commission adopted, as you well know, in May 2007, already 14 years ago, its strategy to address the issues of overweight and obesity. The white paper, a strategy on nutrition, overweight, and obesity-related health issues. The strategy was focusing on action that can be taken at local, regional, national, and European levels to reduce the risks associated with poor nutrition and limited physical exercise while addressing the issue of inequalities across member states. The strategy, which was just partially implemented, and we should continue to implement it, was focusing on addressing the causes and determinants to obesity, and its effects were limited. Science has evolved rapidly over the 14 years, and it is therefore time to update this strategy to complement scientific advances and importantly respond to the prevalence of obesity in Europe, which has increased during this time. All these aspects indicate that obesity needs to be further addressed, and that we need to address obesity from all perspectives, including as a non-communicable diseases. This means focusing on prevention and health determinants, such as nutrition and physical activity, but also focusing on medical causes and treatment. The momentum is here. And we have now the Farm to Fork strategy that promises to also reduce obesity and poor nutrition through focusing on ensuring food security, nutrition, and public health. Horizon Europe, our extremely important research program, the most ambitious in public funding and also in objectives in the world, will allocate funds for public health as well as for research and innovation, also in determining the causes and ways to treat obesity. Last but not least, EU4Health was mentioned. I was the responsible person on behalf of European Parliament, the rapporteur. And this is a very important program because for the first time, we have an appropriate funded program, 5.1 billion, with a lot of good objectives. And this program will allocate resources on a yearly basis to address behavioral risks and determinants such as obesity. And this was one of the areas that I tried to convince the Council, and also with the support of my colleagues from different political parties in the European Parliament, the shadow rapporteurs, we managed to include obesity as one of the areas where this program should allocate resources and concentrate its policies. The EU4Health TOS recognize obesity as a chronic disease and gateway to other chronic diseases, including diabetes, cardiovascular diseases, and certain types of cancer. EU Beating Cancer Plan and fighting against cancer being maybe the most important policy priority in the coming years, of course, excepting COVID-19 and the need to end with these pandemics. But fighting cancer, EU Beating Cancer Plan will be extremely important in the coming years. And we have a good momentum now for health, and we should, as I said at the beginning, take advantage of this. Thank you so much, and good luck in all your activity, and of course, a lot of successes to this very important event. Thank you.
Thank you very much indeed. Well, you're not going anywhere, I hope. Just stay with us a few more minutes. If anyone has any questions, please do put them in the Q&A. Just the idea, just can I ask Professor Van Rossum that if national governments and other organizations are to actually define obesity as a disease, what difference would it make to patients? I mean, somebody actually does point out here that the WHO and the JRC do call it a chronic relapsing disease. So clearly it has its recognition there in some areas.
Yeah, the point is that exactly the WHO is recognizing it as a disease, but it's not accepted by all countries. And it does matter for a lot of, for example, reimbursement. So I just explained the hormonal disturbances, which always make you go back to the higher weight. And that makes it, if people, for example, have already a healthy lifestyle, but they're still obese, then we wait until cancer or a heart attack is there. And we shouldn't do that. We should then start, for example, pharmacotherapy. But if it's not accepted as a disease, there's no reimbursement. I think about less than 1% of the people suffering from obesity is being treated well. So if you see that it's a gateway disease to many other diseases, what we lose as opportunities there. So to accept it as a disease and treat it like that, and also, for example, have the right resources, reimbursements, and take people serious also for the weight stigma, because the problem is we often, also physicians, I'm treating physician myself, but we always think too simple. It's just, for example, if lifestyle induced it, then with a healthy lifestyle, you always get rid of it. And that's not the case. Therefore, prevention is key. So, and therefore, I think the EU is also really relevant. All the farm to fork strategies, really important prevention. But at the same time, all the people who already have the obesity, therefore, we need much more treatment and to take it really seriously.
Thank you. Christian Borsoi, though, obviously there are limitations. We know that in terms of health policy at EU level. And we were hearing there from Professor Van Rossum that it's often national governments who are not prepared to see obesity as a disease. So really, what influence can the EU have on that national piece?
You're right. And of course, you rightly said that most of the decisions are in the hands of the national governments. In some EU countries, of course, there are regional authorities or state level authorities, but EU more and more took responsibilities, and the expectation of citizens, and mainly after COVID-19 crisis, are that EU institutions should react and should act proactively with more and more determination. Of course, the treaties are there. We cannot change them now, but already the signals sent from European level are taken into account more seriously by the member states. So with this program, putting together the ideas and the expertise of our extremely good doctors and researchers from all EU, we could issue policy recommendation, and European Commission, with this political support from European Parliament and from the academic community, could be more, I wouldn't say aggressive, more active in convincing member states to act with more determination in the area of fighting obesity and also treating obesity as a medical condition, as a disease.
Thank you. Professor Van Rossum, I mean, obviously we come back to COVID always. Is this really going to focus the mind more of governments? And where do you see the most potential for endocrine treatments or prevention strategies? I mean, where do you think that the first real action should be?
Yeah, I think this is really also momentum, just as Christian also outlined. I think what we're looking at right now is a chronic pandemic of obesity, and it's collapsing with an acute viral pandemic. And it's obvious, we knew already from the flu, it's more serious in people with obesity. So it's just one of the many examples of the problem of obesity. And where we should do is I think, again, to put in a boat, I think for countries, there's several countries already accepting it as a disease, like Portugal, recently Italy, Germany, and the Netherlands, but many other countries right now. So that creates opportunities for the correct treatment. But I think also we need regulations, because now you see a lot of things. It's voluntary. You stimulate with public awareness. That's also needed, that the healthy lifestyle is important. But actually, the obesogenic environment is really horrible right now. I mean, the supermarkets are full of unhealthy food, and to make the healthy choice the easy choice by, for example, price incentives, but also to forbid, for example, marketing on healthy foods. I think we need much more regulations to make it more easy for people to live healthy, because we make over 200 food choices a day, and about 90% is unconscious. We are being stimulated by our environment to live unhealthy. So it's not an individual issue anymore. It's a public health issue for prevention, and at the same time also to treat well.
Can I just very, very briefly ask you a question that's come in, talking about the definition of obesity? Do you find the diagnostic criteria of obesity, which is mainly body mass index, satisfying? How should they be specified in your opinion? Do you see
I think
that?
it's a very good question. I think also you should take at least into account also the waist circumference, because we're mostly talking about abdominal fat mass, which is the active unhealthy organ if you have too much. And of course, if you're a bodybuilder, you can also have a BMI of 32, which basically would be obesity by definition. That's not the case. So we should look more at the person as an individual and define it better by implementing more. Is there too much fat? Is there dysfunctioning fat? And there define it, not only the BMI, which is more like an epidemiological measure.
And Andrea Giustina wants to come in briefly, but just to say, Professor Giustina, we are running a bit tight on time on this bit.
I know, Kathy. Just a very, very short comment to Lisbeth and Christian. Obesity is a disease. Please, Christian, fight for it everywhere. And really count on us for this, because we need to convince everybody that obesity is not a deviation of some behaviors, but is a disease. So please count on us, fight for it, and good luck, because we need you. Thank you very much.
Thank
Short
you
and precise.
And the rallying call. Thank you very much indeed.
Thank you so much. I totally agree. And of course, being backed by the expertise of endocrinologists and on so extremely competent professors and specialists and medical doctors. And also we should convince many other stakeholders, many other colleagues. I saw Sirpa, which I worked a lot with her on endocrine disruptors years ago, and I'm also said that we didn't manage to advance as much as we wanted to do in this area. And also other colleagues which look closely to these health issues, I believe will succeed. And it's the main message that I'm leaving from this conference. And thank you so much.
Thank you very much indeed. Great message to end that session on. Thank you all very much indeed. We are moving quickly. I told you we were going to be moving quickly. We're talking about rare diseases now, because rare diseases are rare, but there are a lot of them. And there are well over 400 rare diseases that affect the endocrine system. So we want to know what more can be done at policy level to help rare disease patients. Let me introduce our panelists. Jose Valverde, who is the Policy Officer for Digital Health and the European Reference Networks at DG Sante. We'll be hearing more about the European Reference Network, so I won't try to explain what they are to anyone who doesn't know. We will find out. Kostas Alegianis, who is the Public Affairs Manager at the European Rare Diseases Association, Eurodis. Hello to you. Professor Dr. Alberto Pereira, who is head of the Division of Endocrinology at Leiden University Medical Center in the Netherlands, and also coordinator of the ENDO-ERN, the Endo-European Reference Network. So very much the key of what we're talking about today. And then Johan de Graaf is a patient representative from Endo-ERN. So the patient's perspective always absolutely key in all of these discussions. So let me get rid of some papers that I don't need anymore. Otherwise, I'll be asking you questions from the last session. Now, very brief opening remarks from you all. Kostas Alegianis from Eurodis. We're going to talk about the endocrine perspective, but can you give us a brief picture of rare diseases in Europe?
Yes, of course. Thanks a lot for inviting me. I'm very happy to be here. A rare disease in Europe is a disease that affects less than 1 in 2,000 people. So that might sound like there's not many people affected by it, but indeed there are more than 6,000 diseases, rare diseases around the world. So if we calculate that, there's about 30 million people in Europe that suffer from a rare disease or live with a rare disease. That means that it's the combined population of the Netherlands and Belgium. So it is indeed a big number of people, and not a small issue, as the name actually might indicate. Also taking into account that about 80% of those diseases are genetic diseases, many of them manifest themselves in children. So it's also very often a family or a social issue. It's not only a healthcare issue. We ran a survey with more than 7,000 members of Eurodis to find out that only 5% of the people participating in the survey actually think or are using some sort of transformative or curative treatment. So that means that there is a big unmet need. There is a big population that is in need of some action at European level mostly. And here the European aspect is also very important. Because as you can imagine, with such small populations per disease, it is impossible to do research only within a specific country. So we have a big unmet need, and we have a population that really needs it. That is not to say that there is nothing happening at European level. I think all of the previous speakers have already mentioned most of the things that I had in mind. There is the European Joint Program on rare diseases, which is a research collaboration between different institutions. There is the orphan drug regulation and the whole revision of the pharmaceutical strategy going on at the moment. There is the European health data space that we're looking at, which we hope that will bring a lot of new potential for research collaboration. HTA, health technology assessment, is going on at the moment, starting with a European collaboration between different countries, and now hopefully soon in the form of a regulation. But I think the most important is, of course, the Cross-Border Healthcare Directive, which was set up to enable patients to travel between countries, but it also has one element on ERNs that I think others will talk a bit in more detail, which does actually the exact opposite. Rather than the patient traveling, it's the knowledge and the collaboration of different experts in different European countries. So I hope this helps set the scene a bit, and I'm happy to hear from the other speakers.
Thank you very much indeed. And yes, again, you give a picture that there's a lot going on there, but clearly there are still some unmet needs. Professor Pereira, from the endocrinologist point of view, tell us a little bit about specifically endocrine rare diseases and the policies and the networks that exist. So we more about the European Reference Network.
Thank you so much, Katie, and thank you, Kostas, for the kind introduction already of the rare diseases. So you have to be aware that more than 400 rare diseases affect the endocrine system, and rare endocrine conditions are often chronic and life-threatening, and accurate estimations of the economic costs and societal burden are just not available yet. So these more than 400 rare diseases are covered in 4 ERNs, but the vast majority is within endo-ERN, and endo-ERN is also the largest of the ERNs. So endo-ERN covers expertise from birth to old age, and also has a unique governance structure that includes patient representatives in all its layers. And now with almost 80 reference centers in all the 27 EU member states, last year in 2020, almost 12,000 new cases of patients with suspected or confirmed rare endocrine diseases were referred to endo-ERN. And as John Ryan already mentioned, the reduction of pre-existent health inequalities in the EU is the mission of all of us, but specifically for the ERNs for the rare disease cases. So we have the 2 most important deliverables of the network are, first of all, to demonstrate the added value of the multi-expert boards that use telemedicine for the cross-border consultations, and second, to demonstrate structural pathways into science. So with respect to the former, we are very successful in the use of telemedicine tools for this virtual cross-border consultation. So in view of this EU directive of cross-border healthcare, for example, patients affected with a rare condition in Greece can be discussed in a virtual panel with experts from Sweden, France, and Netherlands, but also vice versa. And with respect to the structural pathways into science, we link care to research with the European registries. So all the ERNs now have an international registry, and we believe in these registries because the registries can improve the care of the patients by enabling surveillance, audit, and research through a virtual environment, and they can play a vital role in clinical benchmarking and act as a platform for quality improvement. And the European Registry for Rare Endocrine Conditions, Eureka, does all of this. So first of all, an assessment of quality by numbers, followed by standardization of what is collected, to finally an assessment of quality by clinical outcomes. So if you would ask me and the rare disease community, what would we like to see well, now that these ERNs have reached a certain level of maturity, it really becomes evident that the funding needs to be continued for these ERNs. We are a good example for others with the telemedicine use, but also, for instance, with the epidemiological surveillance of cases, using electronic reporting of cases in our European registries. And this also includes a unique collaboration with the Rare Disease Committee of the European Society of Endocrinology, a COVID-19 task force that includes and maps these cases that are affected by COVID-19. Then we also need coordinated actions and interoperability of these registries, of course. And this can be accomplished through a European Rare Disease Coordination and Support Actions, all under the umbrella of Horizon Europe. And there's an example of a recently established ERICA consortium that does this, strengthening research innovation capacity by integration of ERN research activities. So this will ultimately result in safe, accessible, and efficient access of therapies for our patients. In this respect, finally, the rare endocrine diseases would also benefit from an increasing funding for orphan medicinal projects. So the so-called drug repurposing, so a reform in funding structures to invest in the use of old medicine for new indications. So the use of this telemedicine is, I think, a very good example also to further elaborate on the European level health technology assessment that will need to accelerate all these activities.
Right, thank you very much indeed. So funding and repurposing of orphan drugs, really important. Very impressive what's already going on. And Johan, you know all about the European reference networks because you benefit from one, I think, but you're also involved in advocacy. So what's the missing bit for you then from the patient perspective? What more can policymakers do to help you?
Well, as already said by Kostas and Alberto, the number of patients with endocrine disease conditions is very low on a national level, and international cooperation is key to learn more from each other and share experiences. And what's nice within EndoERN, patients are equally involved in the governmental structure and have the same voting rights as clinicians. And clinicians and patients together determine the course of research and all other kind of things. And that's, I think, very unique from a patient's perspective, that you really have a connection with the clinicians. And also, patients are not just patients, but they are considered as lay experts working side by side by clinicians on clinical guidelines, research projects, and making patient information. And this offers patient representatives the opportunity to exchange experiences and learn from each other. And that will benefit all endocrine patients in Europe. And also, it's important that, for instance, by making surveys within EndoERN together with the clinicians, we already make an inventarization of the needs on information materials and medical research. And we also have published some scientific articles together with clinicians. And I think that's also very unique from a patient's perspective. But one of the things, it's difficult for us to reach out to every patient in Europe. And that has to do with a lot of factors, but also with a poorer patient organization infrastructure in some countries. And one of our tasks is really to bridge the cultural and linguistic differences between patient organizations. And there's a big challenge for us as patients. And one of the things, one of the struggles for us is translating surveys every time in dozens of languages is a continuous struggle, and it all depends on voluntary work, and reaching out to the wider patient community isn't something that is provided for. So it's all voluntary. Patients are already patients, of course, but it's so important to reach out to everyone in Europe.
Fine. Well, thank you very much indeed. I mean, it is very impressive that patient rights are equal to clinicians. As you say, you don't hear that often, so that's very interesting. So, Jose Valverde from DG Sante, you are coordinating the work of the European reference networks. Well, we've heard how important they are, but we know that the more could be done, and a lot of it's kind of funding, I think. But tell me from your perspective where you see the next steps.
Well, thank you very much to the European Society of Endocrinology for this opportunity to present our work. But the first thing I have to say is that the reference networks nowadays is a big success. So there are many other units involved and even in different directions. So I think it's a collective work, and we are giving from B3 the support to the reference network, structural and let's say committees, but also to the European Health Data Space, which is very interesting, and the links to the reference networks. I have to say also that I have read with a lot of interest the white paper, and in special the chapter dedicated to rare diseases. And I think that it is high time to recognize the high impact of many metabolic illnesses and diseases into the health systems itself. And these are not easy. So in many cases, very complex diseases. So let's speak about the reality of year ends. There are, you know, already 24 of them. It is being considered to increase the number if it needs to be covered. There are more than 1,100 units already working in NET, and this is very important. This is more than 400 hospitals across Europe working on rare diseases already in an organized way. And this is a story already with more than 10 years. So in 2011, we already have the first structure things. I mean at the level of the European Commission. You were also mentioning that it is programs, it is funds. And of course, as our director, John Ryan, was mentioning before, EU for Health program in 21-27, of course, has the reference networks included. And I think in even a much better shape than before. So it's, and from the things I'm going to tell you now, you will see that it is reinforced, really. So we are working and continuously working, for example, on the registries. This is extremely important because it will provide data to reach new outcomes and research, but it will also feed our European health data space. Extremely important. We are also working on clinical guidelines to try to get them homogeneous across Europe. So we have been looking for the support of health technology agencies across Europe on this work that societies, clinical societies, are already doing very well. We are in a new phase of evaluation and assessment. So around 630 new units are going to join this year the effort. This means that by the end of the year, it will be more than 1,500 specialized units working in Europe. We have also the mobility program, which I think is something very demanded inside the units, inside the reference networks, because it will allow to interchange not only health professionals, but even patient representatives inside the unit, inside the networks. And this is very interesting. We are thinking on a new patient management system with the lessons learned from the first, and in 2 or 3 years, we will have a new one, which will be much more easier and even mobile. And of course, the integration of ERNs on the national health system is very, very important, both because it will represent the introduction on the clinical pathways of each country, but also on the reimbursement in many cases. But we understand that the heterogeneity of the European health systems makes this a complicated effort that we are thinking that in the next program will also get support. Thank you.
Thank you very much indeed. So you mentioned the EU health data space. Maybe I could bring in Kostas Aligiannis on that and ask you what you hope that is going to mean for the world of rare diseases, because it's obviously then accessing real world data.
Yes, well, it's a bit hard to say at the moment, as we're still waiting for the final proposal of the Commission, but we've been involved over the last years in the preparation of and with different stakeholder consultations and working groups, etc. So I think especially for rare diseases, because of the issue that has been mentioned before by basically everyone, the small populations in different countries and the need for European international collaboration, it is impossible to have this kind of collaboration on a bilateral basis between countries. So having a European framework that will help foster this research and will allow data to flow between borders without having the restrictions of incompatible legal systems, because I think the objective of all the countries is the same, to protect individuals on the one side and find a balance between research and individual freedom. So if we have a European framework that allows to do this for the whole of the EU and not only on a national basis, that would be the main objective, I guess, of the European health data space, and what we look forward to. Yes.
Professor Pereira, then what policies will be the, I mean, we've heard a lot of actions going on at EU level, but really what would be the most important thing from endocrine linked rare diseases from your perspective?
I think that the registries are an excellent tool for that, because these European registries, they fulfill this GDPR related criteria, but the clinical data, so these registries need to be fed. So this clinical data need to be entered. So other policy interventions, they should be focused on patient and institutional involvement and co-ownership of the data. So this will increase the engagement for the institutions and also for the patients. If you are a co-owner, you have shared responsibility. And I'm certainly convinced we already see this also within Eureka, that this accelerates the feeding of the registries.
And Johan, from a patient's perspective, registries are, I guess, are important for you too. But I mean, you talked about. I mean, you've got a lot of sort of day-to-day things like translating surveys, really important. So in the end, is it mainly funding from your perspective that you're lacking?
No, not only funding, but also having the infrastructure working together and finding the patient organizations and the patient representatives. And yes, funding is important because you have to reach out in the language of those people, those patient organizations. Not everyone speaks English on the same level.
No,
so that's very important.
And Jose Valero, we're looking to the future. I mean, do people know about these networks? I mean, you know, the work is amazing. There are 24 of them. How do you publicize them more widely?
Well, you know, the colleagues mentioned already, there are 30 million persons in the European Union with a rare disease, and rare and complex disease. I think this is publicized at the European level very well. What we think it is missing is the integration at the level of the national country, at the national health systems in some countries, because I have to say that in others, this integration has been already fantastically performed. So this is the difference we see. And about I will like to say that about the health data space. Yesterday was published a public consultation, so now it's open for you to comment on that. And of course, registries are going to be, or we want that it will be part of it, really a very important part of it. And here, the key word is the integration. So the interoperability. If we manage that electronic health records, our registries, and also our clinical management system for consultations communicate between them, then we will have a much bigger possibility for our patients to get the diagnostics and therapeutics before.
Thank you very much indeed. And that interoperability was something that Professor Pereira brought up. So that's really important. Well, thank you very much indeed. I know we're rushing through all these themes today, but that's just gave us a sort of real sense of how important these reference networks are. And when it comes to certainly rare disease, all rare diseases, but specifically dealing with endocrine linked rare diseases. So thank you very much indeed to all of you. So we're jumping on now, and we're going to cancer, because if we look at the prevention and we look at the treatment and we look at the care and the quality of life in many cancers, so many depend on hormones. There is really a huge link. So I'm delighted to have with us for this session Jutta Gutterland, who is an Euro MP from Sweden on the ENVI committee. Hello to you. And we have Professor Dr. Monica Marazuela, Chief of Endocrinology and Nutrition at La Princesa Hospital in Madrid. So really nice to see you both. Professor Marazuela, endocrinologists play a big role in beating cancer. We know that, certain cancers anyway. Tell us more about that, how that whole element of endocrinology in cancer.
Hello, thank you, everyone. Good morning. During my intervention, I would like to explain how endocrinology is linked to cancer and how endocrinologists make valuable contribution to beating cancer in Europe. The first point I would like to make is that many common cancers, such as breast cancer or prostate cancer, that we all know about them, they are hormone dependent. That means that these cancers are sensitive to the hormones that are naturally produced by the female or male body, such as estrogens, progesterone, or testosterone. So the treatments that are used for these cancers include anti-androgens for the prostate cancer and anti-estrogens for the breast cancer. And in some cases, these treatments have side effects that include critical functions in the muscle and the bone, such as muscle or bone loss, fractures, or increase in cardiovascular risk. Therefore, endocrinologists should be involved in multidisciplinary teams when they treat this very common cancer. We should be included in these teams. In addition, beyond this common cancer, there are specific cancers that involve endocrine glands that secrete hormones. They are not so common compared to other cancer, but they're still seen, and their incidence is increasing, but unfortunately the detection rate is still low. The most common pure endocrine cancer is thyroid cancer, whose incidence is increasing each year. Currently, there are more than 50,000 new cases of thyroid cancer each year in Europe. In addition to the thyroid, other endocrine tumors can appear in the pituitary gland, in the adrenal, testes, and ovaries. In addition, neuroendocrine tumors can develop from little cells in the neuroendocrine system that is present everywhere, including the stomach, the bowel, pancreas, and the lung. These tumors are rare, they're often misdiagnosed, and unfortunately, when they appear, they are advanced in more than 60% of cases. Another important point to emphasize is that cancer treatment have long-term impact on hormones. Aggressive cancer treatment can result in comorbidities in cancer survivors, such as autoimmune endocrine dysfunctions, metabolic complications, or infertility. Therefore, endocrinologists should provide important contributions to the management of cancer treatments and the quality of life of cancer survivors. For example, a multidisciplinary approach is very important in situations where young men and women need to undergo aggressive cancer therapy. Endocrinologists should be consulted when considering options like cryopreservation of sperm and eggs for later fertility treatments. One final point I would like to make regarding the relationship between cancer and endocrinology is linked to the reasons why several types of cancer are on the rise. My colleague, Liz Van Rossum, just explained how obesity relates to hormones, and the obesity epidemic is linked to 40% of cancer cases. Similarly, the prevalence of endocrine disrupting chemicals, which my colleague Joseph Curl will talk about in a very short time, also has an effect. Cancer, obesity are interlinked with cancer, and these items should be addressed. In population surveys, EDC have, for example, been linked to a rise in testicular cancer in young boys and men, along with other abnormalities. Together with fellow expert endocrinologists, we have developed a response to the public consultation on the Beating Cancer Plan of the European Commission. We're overall pleased with the plan that was presented in February. However, we want to emphasize how important is that the Commission and the UN members include an endocrinology perspective and also take into account endocrine cancer in the implementation of this plan for the prevention, treatment, and long-term quality of life of cancer patients. And now I hand to the MIP Götaland to address what European Parliament is working on. Thank you.
Thank you very much indeed. So, yeah, Jutta Gutteland, we hear there that endocrine-linked cancers are on the rise, and a call for more voice for endocrinologists in the whole cancer fight. Tell us from a political point of view what's going on.
Thank you. Thank you, Kathy, and thank you to the organizers. Thank you for inviting me to this interesting conference today. And also I would like to say thank you to Professor Marazuela for a very important intervention. I think it is a very informative white paper you have there, and also the connecting the issue of cancer to prevention and endocrine disruptors are so clearly pointed out in the white paper. And as the S&D spokesperson on endocrine disruptors, I have to say that these topics are very close to my heart, and I believe we need to work with more, have it as a bigger priority in the European institutions. And I also believe that that would make a very big difference for Europe, for the citizens, and definitely for many people that are diagnosed with cancer, and where I believe endocrine disruptors are one of the causes. So thank you so much for the important and hard work you do in European Society of Endocrinology. I would like to say from the European Parliament point of view, so I answer immediately to what Kathy been saying, that there are many initiatives going on, as you know, and I will also come back to that in fighting cancer. But I still believe that one of the big causes that is also not enough highlighted in many cases is endocrine disruptors. And I believe we need to work in parallel with all that is done for cancer itself, in the work of the European Parliament with the special committee and so on. I believe that we also need to work with the endocrine disruptors in a more holistic way, where we address these substances better in the legislation, so that we protect citizens all over the European Union from having a daily life where they are put at risk with too many substances in their daily life. We know that we have many thousands of chemicals in our daily routines, and they are there when we open food emballage, they are there when we dress ourselves, when we brush our teeth or do the makeup, and we need to make sure that we don't have dangerous ones in our daily life. And this is so important both for us and our human health, and also as prevention from this risk of tumors that been pointed out here, not at least by Professor Marazuela. So thank you for that. I believe we need to do more. And as also been pointed out here, beating cancer should be a big priority for Europe. We lose 1.5 million European lives every year to cancer, and we are many who lost dear ones because of cancer. And I also know that this is the second most common cause of death, and it is also expected to increase, as you all know and points out, by 25% to 2035. So then it will be the biggest cause of death in the European Union. And as many also know and pointed out, it is also a risk that we now in the pandemic will have a more difficult situation, and the number of diagnoses has decreased due to cancelled screenings and diagnoses, and that will have impact on health in the future, and we unfortunately have to expect a uptick after the pandemic. In February, the Commission presented its new Beating Cancer plan, as you all experts know about. It is a broad plan ranging across policy areas addressing the whole chain, from prevention, early detection, treatment, and quality of life for patients. And 4 billion euros are earmarked to this initiative, of course, very important. And as a Social Democrat and member of the S&D group, I welcome, of course, this initiative, and we need to reinforce the coordination and pool research across the member states. The S&D group has been on the forefront calling for the European Health Union, and I think that will also mean more focus on cancer, and it will help us to coordinate the member states even better in several ways. And this I therefore also especially welcome that the Commission wants to step up the preventative measures and tackle the lifestyle issues such as tobacco, alcohol consumption, but then of course also the chemicals. And on the alcohol consumption, I believe one good example is the proposed labeling on alcohol beverage with a list of ingredients. I think citizens needs to know also what we drink when we have a glass of wine or more. But however, we need to be even more ambitious. From S&D perspective, there are at least 5 areas where we would like to sharpen the work on beating cancer. We need to strengthen the plan on ensuring equitable access to quality care and better map the inequalities that are there. 2, we might need to set up minimum standards for quality healthcare to ensure equal rights across Europe. We know it's a big difference, and it's a different situation for different income group, but it's also different between the member states. We need to strengthen the research cooperation in Europe. That has been pointed out today, but cannot be enough emphasis on this, of course. And for example, we need to improve the special care and fight the rarer forms of cancer. And there is where the European Union can do so much when it comes to pooling there. 4, we need to work together with the EU pharmaceutical strategy, and we might need to pool joint procurement to prevent shortage of medicine for obvious reasons. And 5, then we are back on the endocrine disruptors. We need to look at the environmental factors such as exposure to hazardous substances, not at least then endocrine disruptors, and ensure that our actions are aligned with the European Green Deal. And I promise, as the spokesperson on endocrine disruptors, this will be my focus the upcoming year. Thank you. I stop there. I see Kathy looks a bit nervous now, so I stop here. But I have a little bit more, but maybe I will come back to that. Thank you.
Thank you very much. It's quite hard to sort of get the body language right when you just next to each other and boxes on the screen, but thank you very much indeed for that. I mean, you've talked about endocrine disruptors, and the Beating Cancer plan is recognizing that hazardous chemicals are a key factor in the challenge against cancer. So how do you think the legislation, hazardous chemicals legislation, can help, and do you see a greater potential for the voice of endocrinologists in this whole argument?
Yes, absolutely. I really feel that voice is necessary. It is already there. I met lots of scientists who pointed out the link between endocrine disruptors and cancer, different kind of tumors. And I also believe there has been initiatives, letters, and different kind of initiatives the last years to encourage the European Commission and also the European Parliament to do more. And for me and from my point of view, I believe it's important that we look at this in a holistic way. Today we can be protected in one product group, so there are strict limitations to different kinds of chemicals or substances, but then when you meet another product, you're not as protected. And I really believe we need to look, as I mentioned, more holistic. And it is very difficult, but still we have pushed now to have to really do this. And now I think it's time for the Commission to present something holistic and look at these different groups. I'm very proud of the European Union when it comes to the chemical legislation as a foundation, when it comes to the REACH legislation and so on. But I'm not so proud the last years. I believe we are really seeing lots of chemicals in our daily lives, and there are so many reasons for that. Different products that needs to be help with rain protection, or it can be different good things that we need when we dress ourselves or things. And the industry are so clever, and they invent ways to help the products to develop and be better. But that has really a backside of it, and that is that we are so exposed now in our daily life as matters. And I don't understand why the Commission doesn't present something that is more taking everything into account. I would like a new REACH initiatives, but on endocrine disruptors. And I would also like the UN to have a panel on chemicals, the way that we have for climate, and to work with it and make sure that this becomes a bigger deal in the Green Deal in the European Union, but also globally.
Okay, well, that very, very passionate views there. And we are going to have our next mini panel, which is on endocrine disruptors, but some very good points there. Maybe just Dr. Marazuela, I could just finish with you on a more medical side of things. I mean, you talked about the late diagnosis of some of these rare cancers. So how can that be changed? What is the link between the endocrinology and the cancer? What more can be done?
Well, I think part of the problem is lack of awareness. So these tumors are not recognized earlier enough. So future policy should ensure that other medical disciplines are trained in diagnosing endocrine cancers, not just us. For example, gastroenterologists should be trained in recognizing neuroendocrine tumors that sometimes present as gastrointestinal complications in the beginning. We also need to create links between experts. The ARN, it's a very good option. The European Reference Network on rare endocrine conditions could also help us to diagnose these sometimes rare tumors, sometimes not so rare. And we should take into account general cancer policies that lead to earlier detection, diagnosis and treatment. Of course, research funding is also very helpful and could help to improve current diagnostic procedures. So I think we should need to collaborate. That's always very essential in every kind of process in medicine and everywhere. And of course, we will need also funding to make this better and to help each other.
Great. Well, thank you very much indeed. I see that Andrea, Giustina, have you put your camera on to intervene here?
Yes, Katy, just as usual, a very brief comment. Many thanks to Mep Gutland and to Monica for these talks. Please remember that we are speaking not only of classic endocrine gland tumors, but we are speaking of the world of hormonal dependent tumors like breast cancer, which depends from estrogens, prostate cancer, which depends on testosterone. And also, please remember that many new treatments for cancer do have endocrine side effects. So the endocrinologist is really of paramount importance is in all these multidisciplinary teams that deal with tumors everywhere. And I think that this has to be clearly in mind of everybody. Otherwise, we lose a piece of the scenario. Thank you very much again.
No, very good point there. Well, thank you very much indeed to both of you. And you've really sort of set the scene for our next panel anyway, because we're going to be talking about endocrine disrupting chemicals. So thank you, and the health risks associated with that. So thank you very much to both of you. And let me introduce now our next panelists. Giustina de Avila, who is Head of Unit for Sustainable Chemicals at DG Environment of the European Commission, and Professor Dr. Josef Kohler, who is from the Institute of Experimental Endocrinology at the Charité Berlin and co-lead of the ESE focus area on environmental endocrinology. So welcome to you both. Professor Kohler, just give us a bit of the science behind endocrine disrupting chemicals. And just before you do, let me just remind people you can send questions. We have a couple of questions from the last session which are on this subject, so I will put them to our panelists here. So Professor Kohler.
Yeah, thank you. Welcome very much for the opportunity to present the EDC topic, and great thanks also to Giustina de Avila joining this panel on behalf of DG Environment. We highly appreciate her participation today and her great activities in the unit of sustainable chemicals. As stated in the white paper, endocrine disrupting chemicals, I will use the abbreviation EDC, are substances that mimic, block, or interfere with hormones in the body's endocrine system. And you have heard how broad the endocrinology and the hormone is by the interventions of our president. Endocrinologists in Europe, its member states, and all over the globe are very concerned about adverse effects of EDC on the health of people, and even more so on future generations, a question raised already. Apart from obvious effects of EDCs observed in our ecosystem. The endocrine community worldwide, the ESE and members of our sister societies on all continents have provided solid evidence, a lot of epidemiological data, large cohort studies demonstrating that local or global exposure to individual EDCs or their mixtures is associated with adverse health effect for exposed individuals or whole populations. And strongest evidence has been accumulated, especially for the adverse EDC effects on hormonally regulated processes, contributing to the pandemics of obesity and diabetes. And you have heard that there are strong risk factors on COVID complications. So EDCs adversely impact on the development and function of the hormone-dependent reproductive system, including breast and testicular cancers, for example. And this links the EDC issue to the EU Beating Cancer Plan, as you have heard already. In utero, transplacental, or postnatal EDC exposure of the offspring during lactation can lead to later health risks in life, and additionally provokes transgenerational effects by epigenetic mechanisms. We learn about that quite a lot in the last few years. This latter aspect of EDC action may also be particularly relevant for the subpopulations affected by endocrine rare diseases discussed in the panel before. So human health-related observations on adverse EDC effects have strong scientific support by in silico, in vitro, animal experimental, and mechanistic data, all demonstrating clear cause-effect relationships, which is important in the scientific discussion, with evidence relating to the extent and the duration of EDC exposure. So chemicals identified as EDCs, as you have heard by Jutta, are still widely produced, distributed, and prevalent in Europe. They are found in the environment, terrestrial or aquatic life forms and in humans. And European citizens are still in contact with many EDCs contained in various articles of daily life use. So ESE has the impression, however, that the urgent EDC-related health issues up to now do not yet receive adequate attention and action in a foresighted European health policy and on the national levels. ESE highly appreciates the publication of the Chemical Strategy for Sustainability Towards a Toxic-Free Environment last October. This is an excellent step in the right direction in the context of the European Green Deal, and we now eagerly await its full implementation. Though this CSS document announces legally binding hazard identifications of EDCs, inclusions of EDC as a category of substances of very high concern. And this, I think, is a very important point we come maybe in the discussion. And it announces to phase out EDC in consumer product. But we all know paper is very patient. So EU needs now to take action without further delay to implement these CSS announcements by the strategy and to put into effect the precautionary principle mentioned before of our EU constitution. So there are a lot of questions coming up. I will focus on three. Which implementation steps will be taken by the Commission first now? What kind of information, data, procedures are still needed to implement such measures of reduction of EDC exposure of humans and our environment? Will the Commission increase funding of EDC research for development, validation, and application of up-to-date test methods, covering also the other endocrine areas discussed in the context of the rare diseases, for example? And of course, we ask the Commission, how can ESE, the Society of Scientists, support the EU Commission in its CSS intention and possibly provide scientific help against strong pressure groups or opposing member states in the EU control? Thank you.
Thank you very much indeed. So some very, very direct questions there. So Giustina de Avila, tell us a little bit more about where the Commission is on this. There's clearly a lot of frustration out there, and you've heard that, you know, the scientists are saying there is clear evidence of a link to health, and it's also, we know, a big political hot potato. So tell us more.
Hello and good morning to all, and thank you for the opportunity to be here with you today in this important event on the launch of your white paper. And thank you, Joseph, for setting out the scene of what endocrine disruptors are and for reminding us of the challenges that we have ahead. No? So indeed, we have heard the calls from science so already for a while on endocrine disruptors, and I think we can be proud of the program that we have set in front of us with the chemical strategy for sustainability, which is in effect quite ambitious in terms of the regulatory challenges that we have ahead. No, and we want to tackle the main gaps, or rather update our legislation so it's more fit for purpose and more updated to the challenges that we have identified. So I think I can say that at least in the European Union, we are in a brink of a breakthrough in the endocrine disruptor regulatory world, or at least I would like to think that this is what the strategy is bringing, it's the opportunity that is bringing to all of us in the European Union. So you possibly will all have heard of the European Green Deal, which is the most important strategic document of the von der Leyen Commission. And one of the European Green Deal's first deliverable was the chemical strategy for sustainability that has set for the European Union a zero pollution ambition for a toxic-free environment to be achieved by 2030. So the strategy has built on the assessment or evaluation of the chemicals legislation and its implementation throughout the years. We have a very extensive body of chemicals legislation in the EU. And yet we have identified that there are areas that it can be improved. And I think some of the panelists in previous panels have identified also some of the problematic areas. I also agree that that they need to be tackled. So we perform a number of evaluations of this piece of legislation, and also a fitness check of how well our current legislation protects us from the exposure to endocrine disruptors. And the outcome showed a clear need to step up the protection. So the strategy is a response to alerts coming from science and on the risk posed by endocrine disruptors. So as my commissioner, Mr. Sienkiewicz said, when launching the strategy, with regard to endocrine disruptors, there is a need for speed, and we are determined to step up the pace. So more concretely now, what is that we are going to do in practice? So first, we have identified the need to build our changes on the amendment of two of the key pieces of legislation that we have in the European Union. So these are horizontal pieces of legislation. One is the REACH regulation, and the other one is the regulation for classification, labeling, and packaging of substances and mixtures. So the latter is the piece of legislation that we use to identify the hazardous properties of chemicals. So the first thing that we're going to do is establish a horizontal criteria to identify endocrine disruptors. So we will establish hazard classes for endocrine disruptors that will be based on the WHO definition, and that will be built on existing criteria that have already been developed for other pieces of legislation, such as pesticides and biocides, and that will be able to be applied in all specific legislation. So all legislation regulating chemicals will be able to refer to these hazard classes in the classification, labeling, and packaging regulation. After discussions and an assessment, we've decided that from a regulatory point of view, it's better to have two separate classes, one for human health and one for the environment. And this is because some pieces of legislation in the European Union only refer to risk, for example, to human health or for the environment, and not to both. So it's better to have two different hazard classes, so they can be better used for those pieces of legislation that regulate the risks. We also will propose a categorization system. So we will have a category for non-presumed endocrine disruptors and another one for suspected endocrine disruptors. This is the approach that we have today for carcinogens, mutagens, and reprotoxicants. So it's the way that we've used, as I said, for this hazard class, and it's very, very efficient, and it's very good in terms of regulatory response. So it reflects better science and allows scientists to nuance their conclusions on the classification, and also allows the piece of legislation that that give the risk management response to also nuance the response. We will also be looking in the classification, labeling, and packaging to possibility to add new label elements to the packaging and of chemicals. So not necessarily having a new symbol, but maybe having a hazard or precautionary statements added for endocrine disruptors in the labels of the chemicals. And then there is the global dimension, because the classification, labeling, and packaging regulation is the implementation in the European Union of the UN globally harmonized system for classification and labeling of chemicals. So we will try to bring our program also at United Nations level, so at the global level, and try to have endocrine disruptors classification also brought in the UN GHS. And then comes the amendments of REACH, and the amendment of CLP we are doing immediately. It's foreseen by the end of this year. We might run into a bit of a delay, so it will be maybe beginning of next year, but this is one of our most immediate actions. And why? Because all the other responses rely on the identification. We cannot take regulatory response on chemicals if we don't identify them as having the hazardous properties. So this is fundamental building block of all our regulatory response. Then comes REACH. REACH is a horizontal piece of legislation, for those that are not familiar with it, that regulates industrial chemicals, but also covers for gaps that are left by other pieces of sectorial legislation. So what we do in REACH is we require, one of the things that we do in REACH REACH is we require industry to put together information, gather information about their chemicals. This information that is sent to authorities, in particular to the Chemicals Agency, but then is shared with national authorities and with the Commission. What we do with this information is we identify, we need to be able to use this information for risk assessment, but also for hazard identification. So this is one important commitment that we've made in the strategy, is that we need to ensure that this information allows both hazard identification and risk assessment. And this is a very important step, because this information not only is used by authorities, but also by industry to identify risk management measures. So in terms of endocrine disruptors, we want to update the information so that the information that comes in on all chemicals that are registered under REACH allows for this hazard identification of endocrine disruptors. Otherwise, having the hazard classes will not be very useful if we can not use it because we don't have the necessary information. And then very important, I think has also been mentioned, is the more preventive approach that we will be taking in REACH, but also in other pieces of legislation, of sectorial legislation. This is what we call the extension of the generic approach to risk management. So basically, risk management we can do in two ways. Either we look at the specific substance, the specific uses, and what are the risks, and then we regulate them, or we can do in a generic way. So for specific uses already predetermined by the law, for example, cosmetics, for example, toys, or other type of consumer products, we decide that certain hazards are not going to be allowed in the product. And this is the approach that we have today already in place for years for CMRs, for carcinogens, mutagens, and reprotoxicants. So we want to extend this to endocrine disruptors. So we will not have endocrine disruptors in consumer products in the European Union, unless the use is essential for society. And that will be a step that will need to be demonstrated by industry, the essentiality of the use. We also want to extend this approach to professional users, because professional users fall a bit between the cracks in between the worker protection legislation and the consumers. So very often they feel that although they are exposed to the chemicals as workers do, they are not protected by occupational health and safety legislation, and they need to be more protected even than consumers. So we want to also extend it for them. And then finally, I think Joseph mentioned it, we want to also give endocrine disruptor its own place as a substance of very high concern. This is a first step in REACH for substitution. So these are the substances that will eventually be subject to authorization, and they have been earmarked in the European Union for substitution. So another important element is the need to accelerate the development of screening and test methods. It's important that we have in place and validated for regulatory purposes the test methods that would allow us to generate information on endocrine disruptors. And here also we have a number of initiatives, including funding, to improve the methods that we have at hand. So in summarize, we have a big regulatory work plan ahead of us. The amendment of REACH is foreseen, I forgot to mention, by 2022, so for next year. So then it will have, of course, to follow the Commission proposals need to follow the legislative procedure with Parliament and Council. But I hope that at least when it comes to the technical details, this will not be much discussed, but we'll focus on the main political messages that the legislators want to send. But it normally takes around 3 years. But from our side in the Commission, we are working in the next 2 years to put these basics into place. Together with REACH, other pieces of legislation will need to be amended. Also the cosmetics, the toys, etc., to include these generic approaches as well for endocrine disruptors. And not only for endocrine disruptors, for other hazardous properties that we have identified also with COVID. And I heard a lot talking about COVID in particular in the first panel. Diseases that have made people more vulnerable to the COVID disease, and this, for example, immunotoxicants and neurotoxicants.
Okay.
So, but I would just want to finish by thanking the European Society on Endocrinology for all the work. I think it's very important, the work that you provide us in the Commission, all the scientific support, and I hope that we can still count on you in these 2 years to come, because we will need your help. Thank you very much.
Thank you very much indeed. So, Joseph, I want to ask you whether you're convinced that the Commission is stepping up the pace. Just let me read this. Women Engaged for a Common Future, they say they've been battling against EDCs for 25 years. We're convinced that we have to start now to prevent cancers and other diseases. As long as there's not enough legislation which really protects people, it's not going to be good enough. We've lost a lot of time in the past. Industrial interests must not be more important than human health. So, Josef, what's your view from the medical perspective? Is this, obviously it's going in the right direction. Is it enough, and is it the right speed?
I think it's definitely going into the right direction with the CSS paper last year. It's a great step ahead. But as you heard before from our two members of the parliament, the commission had to be sued by the Swedes to really do action, because there was a delay of 20 years. And I think I have some understanding that EU policy has limits at the national levels. And of course, a lot of the health issues and the implementation issues are at the national levels. But I think we have learned from COVID especially that we cannot leave it to all member states to really, the last one to join in 20 years. I think the Commission and the European Parliament, the European Council, which is a major obstacle, has been a major obstacle in the past to implement action, they have to be put under pressure by the science, by the medical community, and last not least by the patients affected. We have seen that a lot of children, parents of young children, young families are highly concerned because they have the knowledge, but the knowledge is really not implemented and is really not put into action. And I think we have to step ahead with, now I just checked it, in April 18 identified EDs, endocrine disrupting compounds, by REACH, but many of them are still in use. There are the pesticides. Half of the pesticides allowed by the EFSA and the authorities in Europe are still in use, albeit we know that at least a third of them will affect the thyroid system, which is definitely not a good thing. So we have to take action. We have to start to phase out, and we cannot wait until the last, let's say, national government agrees to ban a substance. I think there must be more pressure and more action. Otherwise, we will jeopardize the future, the development of these pandemias. We know that endocrine disruptors contribute to the generation and development of obesity and diabetes. And when we wait for another 20 years, we will have another generation exposed and obese and diabetic. This is not a way to go.
Cristina Avila, let me just bring in a couple of threads before you respond. Sandra Jen here says from EDC Free Europe, how can the voice of endocrinologists can also be reinforced for early and more systematic protection against EDCs all over Europe, in particular for children, future parents? We can't wait any longer. So the voice of the scientists need to be heard. We also heard from our speaker from the European Parliament suggesting that there should be a UN panel on chemicals, maybe maybe why not an EU panel on chemicals? Just so, what's your thought then? From everybody's saying it's still not fast enough.
Okay, first on the panel, it's an idea that has been discussed and is currently being discussed under the SAICM project of the United Nations. So it has not been abandoned and is very much in the thoughts of all the participants in those meetings. SAICM has been postponed the last year and this year due to the pandemic, but hopefully it will be renewed. The commitments will be renewed, and the idea of the panel will be brought back and hopefully will be established. The European Union supports the idea. So in terms of the speed, I mean, the issue, I think I can share the frustration of most of the people intervening today because it's taken far too long. We commonly refer to endocrine disruptors in the regulatory world as an emerging issue. It's not emerging. It has been emerging in the last 30 years at least. And it's due time that we take into consideration. And I think it's very clear that scientists have been calling for action for a long time already, by the end of the last century. So I agree with the sense of urgency. I think that the role that the society, but also other scientists, the groups have played is fundamental in raising the awareness and trying to break the false dilemmas that we are commonly confronted with in the regulatory area. So industry coming and claiming that this is not an issue, that we can wait, that we don't have enough information, and putting us into paralysis by analysis. No, that's why one of the ways that we found to bring stakeholders together in the strategy is through a roundtable in which scientists are going to have as many seats as industry and civil society. They're going to be represented there, and we can hear really at regulatory level the voice of science. So this for us was a fundamental win in the strategy when we set up this stakeholder consultation forum. No, now it takes time to make legislation, and not only in the European Union, everywhere else. I just posted in the chat. It can take less time. So in the Commission, we've already found, I mean, we've put ourselves the challenge of 1 year to come up with the amendment of CLP, and only by internal administrative procedure, it's impossible to meet this deadline. Only by finding appointments in the regulatory scrutiny board and doing the necessary consultations that we've put ourselves in terms of the better regulation, it's impossible.
We know it takes time, but I mean, as somebody points out here, then how do you protect people, European citizens, for the next 5 to 10 years while we're waiting for anything to happen?
Yeah. I mean, in terms of let me finish. So in terms of the legislative procedure, it is possible it takes less time. If the Parliament and the Council all have the same sense of urgency and they all agree with the technical proposal of the Commission, which is the technical executive body, it can take less than a year. So that's also a consideration to have, whether the Council and the Parliament can reduce their discussions to 1 year. Now, the problem that we have with chemicals, that is not only endocrine disruptors, it's also other chemicals, carcinogens, mutagens, is that people don't start being exposed in the moment that we decide they are an endocrine disruptor. We classify them. People have been exposed before. So all the exposures that have happened before, we are not protecting from there. And that's why we really need to get our house in order and be able to identify the substances as soon as possible. And that's what we are attempting now with CLP. At least let's get them identified, and then we can take action. What do we do in the next 5 years? We are trying to use our existing regulatory system to step up the protection. And in this case, we have committed to use REACH, and it's a commitment in the strategy, to restrict during this period of 5-7 years until we get the REACH amendment in place, so the REACH amendment adopted, to introduce restrictions that will be as far as possible on groups and as far-reaching as possible. So now we are working on this prioritization setting of which substances we can restrict in the meantime. So we are not decreasing our level of implementation of the current system. We are trying to focus it on the hazard classes that we identify as being of the critical concern, and that includes endocrine disruptors.
Okay, we are sadly really just running out of time, and there are a lot of questions, but maybe we can still remain active on the chat with each other. Thank you very much indeed for your I'm sure that you must feel that, you know, everybody's sort of landing all these questions on you, and you know, you've gave us a very good factual overview of what's happening, and you say also that you want to speed things up too, so don't we all? Thank you very much indeed to both of you, and I'm going to invite Andrea Giustina to come back. Giustina, sorry, I've got your name wrong. How can I when we've seen so much of you? But just to give us a little bit of a sum up of what you've heard, Andrea, in terms of what you think should be the takeaways from the discussions that we've had today.
Thank you very much, Katie, for really sharing in a wonderful way this historical meeting. I'm really very pleased of all the participants' contribution to the understanding of the importance of endocrinology. It is really symptomatic that even a wonderful professional as Katie has problems in pronouncing endocrinology. This is something that really means something.
I keep putting an R in it where there isn't one. I know.
But this is symptomatic, Katie. This is something that really...
You should call it hormonology.
Absolutely.
Yeah.
Absolutely. This is the difficulty in just pronouncing the name of the specialty. Is something that do not have to avoid us to tell the people how much endocrinology and hormones and endocrinologists can be important for our health. And the intervention of the institutions in this and the partnership with institutions is of paramount importance. So the white paper is not the final step, but is the first step in this interaction, in this partnership with European institutions. And I would like to say that really it was a team effort from all the scientists that contributed to this white paper, from the team of the European Society of Endocrinology, led by our CEO, Ellen Gregson, and by our Director of Strategic Partnership, Dirk de Riet, who was really instrumental and the soul of this white paper. And obviously, I have to say a few words on the supporters, on the partners that allow us to do this kind of activities. And we have premium corporate members that really like Ipsen, like Pfizer, like Recordati, like Takeda, which with unrestricted, totally unrestricted grants, totally trusting on us and on our aims and on our integrity, really allow us to do this kind of activities. We advocate for endocrinology and for endocrinologists, but as you have seen, we advocate for the millions and millions of patients that around Europe and beyond do have endocrine diseases. These patients must be taken into account by our institutions. And we are here with the white paper and beyond for helping the institution taking care of this huge, huge problem. Thank you very much for everything, and to all the people that were willing to participate in this historical launch of our white paper.
Well, thank you very much indeed. And just very briefly, Andrea, just in terms of COVID, we started with COVID, we'll finish with COVID perhaps. You know, do you think that this is in a way your moment, in a horrible way, because obviously nobody wants to be brought into the spotlight for this reason, but where do you see then the role of endocrinologists in the end of this pandemic and, you know, preventing others?
Katie, thank you very much. Let's say a few words for what endocrinologists did in the COVID pandemic. Endocrinologists were recruited all over the world in first line against the pandemic, in the fight against the pandemic. And I have to say thank you to all of them who helped the health systems everywhere in fighting COVID-19. But also the endocrinologists were instrumental, because from the beginning of the pandemic, I remember a letter that I wrote to the British Medical Journal in March, saying that possibly lack of vitamin D was particularly impacting on the severity of COVID-19 in countries like the Mediterranean countries, like Italy, like Spain, where you think there is a lot of sun and there is a lot of vitamin D. Unfortunately not. We don't have enough vitamin D because the people don't go into the sun, stay in the offices, stay in their homes, and they no more have enough vitamin D. Whereas the Scandinavian countries do have enough vitamin D because they fortify food with vitamin D. We don't do that. And this is something that it's an easy thing to be done. Convince everybody to fortify food with vitamin D. And the European institutions can have the power to convince the people to do it. So I think that endocrinologists have been instrumental in discovering the endocrine phenotype of COVID-19 and will be much more instrumental in preventing other pandemics, protecting and curing the patient with diabetes, with obesity, with vitamin D deficiency. We just need the institution to help us to put enough money into research and to the help of those people that really care for this patient to do this and to do this effectively.
Well, thank you very much indeed for closing the meeting in that way and bringing all together a few of the threads. It was a real rush through lots of subject areas, but in a way, you know, it gave a real sense of all the different areas where endocrinology is so key. I'd like to thank all of our speakers and for everybody who's attended. Just to tell you that the white paper will be sent to all participants, so you will be able to read it in much more detail, because obviously we've only skimmed across certain elements of it. So I'd like to say thank you to everybody involved, and enjoy the rest of your day. And I hope you will join us for the next time, because there will be a next time, I'm sure.
Thank you, Katie. Thank you, everybody. Ciao.
Thank you. Ciao. Ciao.